We are live now, Doctor. You can start the session.
Great. So hi, welcome everybody. I'm Dr. Aditya Sethi. I'm the treasurer of Young Ophthalmology Society of India. This is a memorable day in the history of Young Ophthalmology Society of India because we're going to tie a MoU with the Polish Academy of Ophthalmology. And we have Dr. Adam and Dr. Anna as front runners from the PAO. And we're going to talk about diabetic retinopathy and how to tackle it, how they've been tackling it in Poland, including imaging. So Dr. Adam is a key member of both societies now because of whom we have been able to tie up this MoU. And we'll be doing the MoU launch at the end of the talks. And we have Dr. Dipanshu, Dr. Bhavik, Dr. Vaibhav, and Dr. Prasanna here from YOSI who are going to take over the podium and guide the webinar. We'll start with the academic talks because that's the motivation of being here. And then we will move on to a group photo and describing the MoU later. Dr. Diva Kant, our president, will also be there, and he's also a very successful retina surgeon from India, and he'll be gracing the occasion along with Adam as signing of the MoU. So over to Dr. Dipanshu to introduce our Polish speakers and Dr. Prasanna to introduce our Indian speakers.
Thank you, Dr. Aditya sir, for the introduction. A very warm welcome to all the Polish delegates and from Indian Young Ophthalmic Society of India. I welcome, on behalf of YOSI, I welcome Dr. Anna Nowinska. Madam is professor in the clinical department of ophthalmology and faculty of medical sciences in Zabrze, and also at the Medical University of Silesia in Katowice, Poland. We welcome you, ma'am. And also, I would like to welcome Dr. Adam Balkela. Sir is his research his research was from University of Kentucky, and he began his ophthalmology training in 2021. Also, sir is a fellow of the Bascom Palmer Eye Institute, and he is currently working in Poland. We welcome you, sir, on behalf of YOSI. Over to you, Prasanna, to please introduce our Indian speakers today.
Yeah, thank you, Dipanshu. So first, I would like to welcome Divakant sir. He has joined us. Welcome, sir. So along with sir, I would also like to introduce Dr. Dipanshu, again my co-moderator, who is also very active part of YOSI, who also heads the medical legal as well as the ocular trauma initiative of YOSI. And we have two vibrant and dynamic speakers. We have Dr. Vaibhav Sethi sir and Dr. Bhavik Panchal from behalf of YOSI. So looking forward to a very vibrant program again. So this is the agenda of today. So we'll have the lecture by Professor Anna first on therapeutic strategies for persistent DME, followed by our own YOSI speaker, Dr. Bhavik. So who will be addressing the Indian perspective and the challenges on DME. Then we'll have Dr. Adam on the multimodal retinal imaging. And then last but not least, we are going to cover on some bleeder and breaks, the crucial lessons from diabetic vitrectomy. So a few words from Divakant sir before we start the scientific agenda.
Thank you so much, Dr. Prasanna, and heartfelt thanks to the Polish Academy of Ophthalmology for joining hands with the Young Ophthalmologist Society. So as you know that ours is a very young society, less than 40 years of age, and all of us are very keen on collaborating with colleagues and seniors from all across the globe. It's a wonderful opportunity for us to interact on this platform, discuss perspectives from both the countries, and hopefully help each other in growing as an ophthalmologist and helping our patients as well. So over to you, Prasanna. I welcome all of you.
Thank you, sir. Dipanshu will call the first speaker of the day.
Can we have Adam? Sorry, I'm interrupting. Can we have Adam to say a few words before we move on to the scientific side?
Okay, thank you very much for this great opportunity that we share together, what we learned from that we can differentiate and also see how patients are treated in India. It's also great for us and for our doctors. So we are very happy to collaborate. We are also very keen on signing this mode of understanding and having our future collaboration together. So thank you very much. Maybe Professor Nowinska would like to add something.
Well, thank you. I would like to welcome you all, and I am really grateful that we are here together and we can start this exciting collaboration. And I hope that's going to be very fruitful both for scientists, researchers, and our patients. So I'm really happy that we joined our forces to collaborate.
Thank you, Dr. Adam and Dr. Anna. So let's kickstart today's webinar. First up, I would like to welcome Dr. Anna Nowinska for her talk on therapeutic strategies for persistent DME, the Polish approach. Over to you, ma'am.
Okay, thank you. I will try to share my screen with you. Okay. Is my presentation visible? Can you hear me? And can you see my presentation? Okay.
Yes, audible as well as visible, ma'am. Thank you.
Okay. So, dear participants, I would like to share the basic principles of DME treatment program, which was introduced in July 2021 in Poland. And the treatment within the therapeutic program is free for our patients, for all diabetic patients, because it is financed by the public insurance. And well, the treatment is available for all patients which fulfill the inclusion criteria. And currently, almost 25,000 patients are treated within the program. And here is the basic tables showing the number of patients and the drugs which are used within the program. And the first line of treatment include bevacizumab, and majority of patients are treated with bevacizumab, but also other drugs such as aflibercept, ranibizumab, dexamethasone implant, brolucizumab, and faricimab are being used. And here is the step-by-step approach of our treatment. Bevacizumab treatment is started with 1 injection per month for 5 consecutive months. And after 1 month, there is an assessment of the treatment. So the treatment is evaluated. And criteria for assessing the response of therapy include an improvement of visual acuity by at least 1 line on the Snellen chart, and a reduction of CRT by at least 20%, or a reduction in retinal thickness below 300 microns. And at this point, if the treatment is effective, the patient is continued to be treated with bevacizumab, but with less frequent injections, mostly every other month. But if the treatment is not effective, if the evaluation criteria are not met, then the doctor has an opportunity to switch. And the switch can be to another anti-VEGF drug, such as aflibercept, ranibizumab, or brolucizumab. There is an opportunity to switch to faricimab or to switch to steroids. So let's discuss case descriptions of patients from our program. Here is a typical patient with DME. The visual acuity at the qualification visit is 0.6. The central retinal thickness almost 500 microns. And assessment after 5 injections of bevacizumab. As you can see, both on the scan and on the charts and on the graphs, there is an improvement in visual acuity, and there is an improvement in central retinal thickness, the decrease of the thickness, and also the morphology is improved. Another patients, and I think that we would all like our patients with DME to respond to treatment in the way as in this example of this 63-year-old patient. whose initial parameters were visual acuity 0.5 and central subfield thickness almost 400 microns. But after 5 injections of bevacizumab, visual acuity improved to 0.7 and retinal macular thickness decreased to 279 microns. So there is a significant improvement in morphology, retinal macular thickness, and improvement of function because there is an improvement in visual acuity. Unfortunately, it turns out that we are observing the presence of quite significant group of patients who do not respond to treatment with bevacizumab in such a perfect way. And visual acuity and retinal macular thickness are 2 basic criteria for the effectiveness of DME treatment. And those are criteria which we use in our treatment program, as well as those are the criteria which are used in clinical trials or research studies. However, it is worth mentioning, and it's underlined in this table, that in the literature there is a lack of consistency between the criteria for the lack of effectiveness of anti-VEGF drugs and the definition of persistent DME. And for those reasons, the presence of persistent DME, despite treatment of anti-VEGF drugs, is estimated in the wide range of % of patients, from 30 to up to even 70%, depending on the study and depending on a specific publication. And here I am showing 3 examples of patients: patient number 1, patient number 2, and patient number 3, who, despite of regular anti-VEGF treatment, do not have any improvement. And there is a comparison of qualification visits and assessments after 5 every month injections. And as you see, there is no change in morphology and there is no improvement of visual acuity. And I will be showing examples of patients who were switched to either aflibercept or faricimab or dexamethasone. But I cannot change the slide. Give me a sec. Okay. So here is an example of a patient which initial treatment was ineffective. At qualification visit, the retinal thickness was over 300 microns, and after 5 bevacizumab injections, there was no improvement in morphology, there was no improvement, even worsening in visual acuity, and there was a persistent DME diagnosed. But after a switch to aflibercept, both morphology and visual acuity has improved. The same patient, but this is presented as graphs. So you can see that visual acuity didn't improve while the patient was treated with bevacizumab. And then after switching to aflibercept, the visual acuity has improved. And the same with central retinal thickness, no improvement while within the treatment of bevacizumab. And then after switch to aflibercept, the thickness has decreased. And another patient, probably even more interesting, because the patient didn't respond to bevacizumab and didn't respond to aflibercept. And the patient was overall treated with 10 anti-VEGF injections. And as you see, let's look at those OCT scans. There are multiple hyperreflective foci. There are large intraretinal cysts, and the edema is quite significant, over 600 microns, despite 10 anti-VEGF injections. And this is assessment after 5 bevacizumab injections and assessment after another 5, but aflibercept injections. But a switch to dexamethasone was effective. There was a decrease in central retinal thickness, But in this case, however, it was only morphological improvement, but without improvement in visual acuity, which was most likely caused by chronic persistent edema and permanent morphological changes. And the same is shown on the graph. As you see, no improvement during bevacizumab and during aflibercept treatment, and steroid injection was the first injection which allowed the central thickness to decrease. And another patient, even more complicated, the initial treatment with bevacizumab didn't cause improvement. Another switch to aflibercept, also no change in morphological parameters and also no improvement in visual acuity. So there was a switch to dexamethasone, and as you see on the graph, after each dexamethasone implant, overall it was 4 dexamethasone implants, it was an improvement, but it was for a very short time. And then the DME recurrence. And at the end of 4 injections of Ozurdex of dexamethasone treatment, there was a marked diabetic macular edema with subretinal fluid, with intraretinal cysts, and the central retinal thickness was almost 500 microns. So finally, a switch to faricimab was decided. And here on the scan, after the first, after the second, and after the third injections of faricimab. And actually, it was the first drug which provided an improvement for this patient, both in visual acuity, it improved to 0.8, and both in morphological. As you see, the morphology of retina is quite normal. And the same patient, but the graph results, no improvement during bevacizumab, during aflibercept, during dexamethasone, and the improvement after switching to faricimab. And here are the main reasons. I listed the main reasons for ending the therapeutic program. And actually, there are 3 main reasons. First is the improvement and stabilization of parameters. If there is such improvement, the visual acuity is improved and both morphologic is within normal range, we can observe the patient. And if there is a relapse, if there is a recurrence of edema, the patient can be qualified for the program, for the treatment again. The second reason is that the exclusion criteria are met. And the third reason, which is quite often in such group of patients, in young diabetic patients, it's about compliance due to many reasons: work, other appointments, hospitalization, general illness, or surgery. And here I listed reasons for ending the therapeutic program, morphological reasons. If there is an extensive photoreceptor atrophy, if there is a significant and persistent disorganization of internal retinal layers in the foveal area, if we diagnose ischemic maculopathy, those are all signs of a poor prognosis. So the patients are excluded from the program because we know that treatment with anti-VEGF would not bring any benefits for those patients. And if there is a dominant epiretinal membrane or vitreoretinal traction, then we decide to perform surgery, to perform vitrectomy. Of course, if after vitrectomy there is a still persistent edema in the macular region, the patient can be qualified to the program, and the patient is treated with bevacizumab and then can be switched to other options. So to summarize, given the complexity of pathophysiology of DME, we should all consider different therapeutic options in our program. So we start treatment with, usually we start treatment with anti-VEGF with bevacizumab, but we also have other anti-VEGF drugs. We also have anti-VEGF and anti-Ang2 faricimab. In some patients, steroids are more effective. We should not forget about laser therapy, either conventional or micropulse. And in Also in special cases, such as vitreoretinal tractions or epiretinal membranes, we should consider performing vitrectomy. Thank you very much.
Thank you, Dr. Anna. That was very insightful talk. I have a few questions. What is your go-to drug in like a treatment naive patients? Do you guys prefer only bevacizumab at the first go, or
Yes,
you do go for
yes,
higher molecules?
In our program, therapeutic program, which is, as I said, free for patients and it's paid by public insurance, we start with bevacizumab, 5 every month injections of bevacizumab. And if this is effective, we then decrease the frequency of injections. If this is not effective, the doctor can switch a patient to other anti-VEGF drugs, can switch to faricimab, or can switch to steroid treatment. Steroids are administered within the program every 4 to 9 months. So it's not every 6 months, but there is a range from 4 to 9 months. And as I showed during the presentation, actually most patients respond to treatment. We can switch to aflibercept, then to steroid, then to faricimab. So most patients actually have benefit from such a treatment.
So, Dr. Anna, very nice presentation and very comprehensive. And we could see a lot of similarities between the protocols that we follow in India. In India, we mainly go for 3 injections initially as a loading dose. I saw in your presentation that you go for 5 doses. So do you see, and then we switch to PRN or treat and extend. So do you see an advantage with 5 loading doses in your patients?
Well, actually, we use 3 injections, 3 loading injections in AMD patients. But in diabetic patients, we observe that the retina tends to respond a little later. So we decided that 5 injections are the best solution. According to European Euretina guidelines, it's like you said, you should evaluate after 3 to 6 initial loading injections. So we decided to choose the number in the middle, that it should be unified for all patients. We have a lot of patients, and all the scans from Polish patients are evaluated by the coordination team. So we decided that 5 is our fixed number, and actually it's working quite well for our patients.
Great, great. So, for example, if you see that the patient has responded with a single injection or say a couple of injections, do you still go ahead and go with 5 injections?
Well, actually, it depends on the qualification status. It depends on our initial parameters. If there is only a small, not significant edema, for example, 320 microns and good visual acuity, and there is response after even 1 or 2 injections, then we can stop the treatment and observe the patients. And if there is a recurrence, you can always go back to such a treatment. But when there is a persistent edema, significant increase in retinal thickness, like about 500 microns, and visual acuity about 0.2, 0.3, then usually we go with 5 loading injections, and then we go to treat and extend and evaluate if there is a stabilization of visual acuity and retinal thickness. So it depends from patient to patient. But yes, there are some patients which we treat only with 1 or 2 injections and then skip the treatment and observe and wait for recurrence.
Right, great. And see, in India, most of the injections are not covered by the government funding. So most of the patients do pay for their own injections. So it's very difficult to counsel and inject because they have to pay out of their pockets. So the situation, that's why, is a bit different in India. And bevacizumab, is it approved by the government? In India, it is not, but we had some changes in the regulations, so we do give it. And how do you go about, allocating the drug, and how do you use it in your country?
Excuse me, which drug? Because
Bevacizumab.
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 Bevacizumab. We use Avastin because Avastin has a lot of positive research and positive feedback. So we mostly use Avastin at this time. But I am aware that there are a lot of bevacizumab biosimilars, which are also used in a few of our departments, and they are also allowed in Poland.
Okay.
But at our department, we use original.
Thank you for all the insights, Dr.
Thank you.
All right. Shall we move to the next speaker?
Please,
If there are no
Dipanshu.
more questions.
Yeah.
All right. Thank you. So, thank you, Dr. Anna, for that insightful talk. And now we would like to move to the next speaker of the session. That is by Dr. Bhavik Panchal. So, Dr. Bhavik will be speaking on addressing persistent DME in the Indian context, innovation and challenges. Over to you, Bhavik, sir.
Yeah, thank you so much, Team YOSI. And am I audible first of all?
Yes.
Yes, you are, sir.
Okay, wonderful. So I hope you can see my slides as well now.
Visible, sir.
Right?
Slides are visible.
Wonderful. So first of all, thank you so much, Dr. Novinska, for this wonderful.
Visible, sir. Can you put it on the slideshow?
Yeah, it's in the slideshow mode.
Yes, now it is. Yeah.
Okay, might be some lag. Yeah. So first of all, thank you so much, Dr. Novinska, for introducing the topic and giving us nice case, the basis for this challenges in management of persistent diabetic macular edema, and to Divakan your questions about affordability and how we tend to assign what anti-VEGF to be injected, right? So yeah, there we go. Right. So my talk is going to be more of an overall comprehensive picture of what are the challenges, not just related to biomarkers. So before we start, just to give you an overview, in 2019, that is around 5 years ago, pre-COVID, we had 77 million people with diabetes. However, the projected number in 2045 is roughly 134 million, right? But it is just the tip of the iceberg. Around 40, close to 45 million people are not even diagnosed with diabetes, okay, with the high HbA1c levels, and they will just going to drop into your clinic, right? So this is something which is dreaded, and we have to take measures. So coming to the topic of persistent diabetic macular edema, what is persistent diabetic macular edema? It refers to macular edema that fails to resolve or shows insufficient improvement despite standard treatments, that is anti-VEGF therapy. If you look at the various publications have various defining criteria, the anatomical definition is less than 10 to 25% reduction in central retinal thickness after 6 months of treatment. Whereas visual response is gain of fewer than few letters, or that is 1 line, or loss of more than 2 lines of vision. Right? This is multifactorial, vascular, inflammatory, and metabolic pathways. We'll go through it. If you look at the incidence, close to 35 to 65 patients worldwide show an inadequate response and can be labeled as having persistent diabetic macular edema. And chronic persistence is observed in nearly 50% of these patients after 2 years of treatment, in spite of aggressive management. So there is patients with compliance, still they can go into persistent diabetic macular edema. Briefly, I'll introduce with a case. This is an mid-50s gentleman who presented to us in 2016 with such kind of OCT picture with a diabetic macular edema which appeared chronic. He had already taken multiple bevacizumab injections in the past. Now, if you look at him in 2017, 2018, post multiple bevacizumab, Ozurdex, vision was low, 2600, same with left eye as well, right? So jumping back to this directly in 2020, before COVID. So he had an improvement in the right eye with this multiple injections, cocktail therapy. Now, but the problem was there was this recurrence of the edema. It was persistent. Okay, and it was all chronic. So what do we do now? So one treatment modality what Dr. Anna mentioned about switching therapy. So when we had the opportunity, he had taken multiple aflibercept in the past, we realized that it's time to switch over to faricimab. And the response was fantastic. In just a month's time, we had a disappearance of all the cysts, vision improved, and we planned for the left eye as well. Though the edema is in April, now he has received at least 3 faricimab combined in both the eyes. The edema has recurred. The idea is that there are challenges which we have to understand before we start managing treatment for persistent diabetic macular edema. Okay, the first challenge is resistance to treatment. So are we going through some global challenges, then figure out and present a concise manner of the Indian challenges, the challenges which are particular to India. So one first is non-responsive to anti-VEGF. Okay, we try to give bevacizumab, and then we realize, okay, it's not working, switch over to ranibizumab, it's not working. Okay, at the same time, tolerance also develops to the drugs what we inject. Second is chronic inflammation. So we know that diabetic macular edema, VEGF does play a role, but it is not just VEGF. There are things apart from VEGF as well. Okay, like inflammation. There are cytokines which are released and they are not addressed by the anti-VEGF. That is where role of corticosteroids is present, but it has its own side effect profile. Third is poor glycemic and systemic control. Uncontrolled diabetes, hypertension, dyslipidemia, they all perpetuate diabetic macular edema. Right, so a higher HbA1c level, higher lipid profile level, dyslipidemia. In spite of treatment, you are going to have recurrence of the diabetic macular edema. Then we go to certain damages or the structural challenges, that is irreversible damage which is happening. There's outer retinal atrophy, what Dr. Anna showed in a very nice OCD where there's complete loss of the outer retina, drill, okay, retinal thinning, or macular ischemia per se. So Octa can help us out here in identifying widespread ischemia, macular capillary non-perfusion, and so on. So the compliance issues also plays an important role. The burden of treatment, right? Fatigue to the patient, regular intravitreal injections, frequent follow-ups, cost involved, travel involved, you need an attendant as well, right? There can be phobia of the needles, repeated procedures, chronic fatigue. So these all factors also play an extremely important role. So other limitation, if you look at the challenges that we just have just two medications, two therapies. One is anti-VEGF and corticosteroid effects. If these two are not working, we do not have anything else. So we are helpless there. Okay, so these are certain challenges that we need to keep in mind. Apart from that, we know that there can be coexisting ocular conditions like epiretinal membrane, okay, or vitreomacular traction that is not going to help the edema to go down or the retina to be settled. If we discount all of this, still there will be individual differences. No two individuals or no two OCTs of those individuals are going to respond exactly in the same manner if you're giving the same drug to them at the same point in time. So you have to understand the mechanisms or the environments as well. Those factors play extremely important, genetic, systemic health, and so on. Next is the cost and availability. One second. Yeah. So we spoke about faricimab, we spoke about brolucizumab, Ozurdex. They're all expensive. Unlike the West or maybe in Poland itself, what Dr. Nowinska mentioned about they're being part and covered under insurance or the government provides, that is not the case in India. So if you do not have insurance, it comes at a price. Now, if you look at the challenges in the Indian context, okay, the first major challenge is the late presentation. Patients with diabetic retinopathy present only when significant vision loss happens. Right? They assume that it's going to improve just by waiting, and I'm not going to go to the doctor. So that causes a lot of damage, and the chance for us to treat early is very less. Second is limited access to specialized care. Okay, so I think only the tier 1 cities or the urban areas itself you will find services, retina specialists being available, presence of imaging modalities like OCT, FA, and so on. Okay, so smaller centers may have some imaging modality, but lack of the correct doctor, anti-VEGF. So patients have to travel a lot. So this again causes delays and poor compliance. As I mentioned, financial constraints. Monthly anti-VEGF injections can average between 20,000 30,000 rupees. It places a burden on the family. Okay, and with limited insurance penetration, it is difficult, and there is less, again, compliance is lost there. The fourth important factor is poor diabetes control. Okay, diet also plays a role, which is again another point here. So coexisting hypertension, dyslipidemia, and both if poorly managed, along with poor diabetes control, just giving injections is not going to help. So that leads to persistent diabetic macular edema. The basis of all of this is lack of awareness. So low health literacy also plays a role. I'll not say in majority of the country also is improving, the health awareness is improving, but it is not to the extent what we desire. Okay, so coming to compliance issues, missed follow-ups, treatment fatigue, as I explained, this is a point which is repeated here. Yes, so variability in clinical practices. As you mentioned, you have a protocol where everyone starts with bevacizumab. That is not the case here. Some may start with bevacizumab, some may start with the biosimilar, some may start with the steroid. So all these factors also, we cannot assess how is the outcome, whether it is optimal or suboptimal. Okay, limited adoption of advanced therapies. In certain smaller centers, tier 2, tier 3 cities and all, the penetration of these newer agents like the dual pathway inhibitor, brolucizumab, may not be that high. So those patients are deprived of such kind of treatment options. So again, this leads to persistence. Okay, the survey article for diabetic macular edema, which is persistent, clearly mentions that bevacizumab given alone and not switching gives around 45 to 50% of patients after 2 years having persistent diabetic macular edema. Switching to ranibizumab or aflibercept definitely helps, and the newer anti-VEGFs. So overburdened healthcare system as well, right? If you're a retina specialist seeing a large number of patients, you cannot actually sit down and have a personalized treatment algorithm for the patient. And as I mentioned, dietary factors does play a role. High carbohydrate diet and use of alternative medicines as well for control of diabetes. So these factors worsen. How do we overcome these challenges? Awareness campaigns, screening programs, subsidized treatment from the government point of view, partnership with the government, telemedicine solutions for patients who cannot travel this far, and capacity building. This is a long-term thought process. Finally, the last part of the presentation, innovations to mitigate the challenges. As Dr. clearly explained, Dr. Novinska, about faricimab being a dual pathway inhibitor, that really helps because we are not just targeting the VEGF pathway, we are also looking at the inflammatory cascade as well. Okay, and we have studies like yosemite-rhine, which have already showed better response in patients with treatment naive as well as patients who had a chronic edema. Sustained release implants again helps those patients who cannot visit frequently, who can come once in 4 months, 6 months, come from far off. That really helps. Okay, so reduce injection frequency, improving the compliance. Yes, combination therapies. This is, I think, one of the most common therapy that we use in India. Even 3 loading dose of injection sometimes becomes difficult for a patient. So after the first or the second injection, we may have to switch over to steroids, so give a gap to the patient to reduce the treatment fatigue to those patients, to those individuals. Okay, and we see good response of combination of anti-VEGF with corticosteroids. The newer therapies, that is RGX-314, it's a gene therapy. This is still in the experimental stage, which is adenovirus-associated vector. This reduces the need for repeated injections, and I think this is also a big boon to the treatment for all our patients. Novel drug classes like kinase B1 receptor antagonist and plasma kallikrein inhibitors. As I mentioned, as of now, we have only anti-VEGF and steroids as our main weapons against DME. Addition of these trials these drugs will definitely help us in our goal of resolving the diabetic macular edema. Personal therapy, yes, personalized treatment interval. Okay, every patient may not require 3 months, 4 months. Some patients may require once a year injection, some may require once in 2 years, some may require monthly. So that is where AI can definitely help us identify which patients, based on the biomarkers, need injection at what point in time. Right. So these are some examples of the duration of edema causing the complication, like bridging retinal processes, pearl necklace sign, predominantly inflammatory markers like hyperreflective foci, and the poor markers, biomarkers like drill, ALM discontinuity in crystalline deposits. When these are present, you know that you're facing a difficult challenge to manage. This is where role of non-invasive therapy like laser treatment comes into play. Okay, micropulse laser, focal laser still has a role. Right? And yes, of course, artificial intelligence to analyze the OCT images to predict the treatment prognosis, as well as the time when the patient can visit the hospital, the clinic. Okay, so and telemedicine. So you can just sit at one place, diagnose the condition, patient can go to a nearby place and get the injection done. These are all for future goals, but this can definitely help reduce the burden of diabetic macular edema on the existing scarce number of retina specialists across for this entire population of 1.4 billion. Somewhere down the line, you have to understand that if it's not improving, you should have a factor which is not allowing the macular edema to go down. It can be an epiretinal membrane, which is taut. It can be a posterior hyaloid, which is prominent, persistent. Okay, or it can be just a vitreomacular traction. For this, you need a surgical intervention. Last but not the least, nanoparticles, microparticles. Again, better drug delivery to the specific regions, maybe targeting the cells. Okay, so that will help us a lot. And not to forget, it is a systemic control. It's a systemic disease. So we have newer therapies like fenofibrate has been shown to reduce DME progression, as well as if you look at SGLT2 inhibitors that help in preventing the vascular leakage and reduction of the DME itself. So finally, innovations have expanded the treatment armamentarium for persistent DME, addressing the unmet needs through better efficacy, durability, and patient convenience. We have to combine these approaches with systemic optimization and imaging guiding decisions for better potential long-term outcomes. Thank you so much, and thank you for this opportunity, Team YOSI.
Thank you, Dr. Bhavik. That was very extensively covered topic on various etiologies of persistent DMEs and how probably it can result in persistence. So my question to you is, sir, that when do you consider switching? Like, when do you consider that probably that the edema has not responding to it, has become non-refractory and not responding to the primary modality of treatment that you have chosen?
Yeah. So thank you for the question, and I think it's a very important question in this context.
Was I audible?
Yeah. So see,
Yes.
in the ideal scenario, if you're giving a loading dose of 3 injections, that is ideal of bevacizumab or ranibizumab. Okay, and after that, if you're seeing that, you can compare it with what is happening to the baseline. Okay, I will suggest that at least for 6 months you continue the treatment. Maybe you want to switch over to a steroid in the interim period. That's a different call. But at least wait for 6 months to take a call whether this anti-VEGF is working or not. But with the newer anti-VEGFs, and if the patients can afford it or have the insurance, you can always go to the higher end anti-VEGF as well, because we have seen that there is definitely a better response. Again, that reduces the number of visits for the patient. That is finally the line where the patient has to come multiple times.
And also, like among the recent molecules like brolucizumab, aflibercept, and faricimab, like which is your go-to drug in these patients? Which one do you feel has better results? Yeah.
So it depends. It's a treatment-naive patient, and it is a very minimal edema. Even bevacizumab works wonders. Okay. However, if the patient is coming to me with already chronic edema and too many cysts and the biomarkers are poor, we can always switch over, or rather not switch over, start with an aflibercept or a faricimab as well. Okay, that is one aspect.
All
but
right.
here the decision is
Any other
not so
questions?
simple, because
Yeah.
the decision is also made along with the considering the financial aspect of the patient as well. So in the clinics, it's very different from what we see in the trials.
I have a question. A very good presentation, Dr. Bhavik and Professor Anna. And I think the question would be that in persistent DME patients, which you be doing OCTs on every follow-up, are there any biomarkers that you look for, which you, in your experience, have you seen that this particular biomarker does well or it improves with a certain anti-VEGF injection? So would you switch an anti-VEGF just based on any biomarker which has evolved or which has increased or which has reduced?
Yeah,
Professor
Anna
Anna?
first.
Regarding OCT biomarkers, there are still mixed results. There are some biomarkers which are more present in inflammation and point out to inflammation, but still, in my opinion, not enough proofs to guide us in clinical practice. So I do not have any special one OCT biomarker. Usually when there are few biomarkers, significant increase of retinal thickness, large intraretinal cyst, a lot of hyperreflective foci and subretinal fluid, then in my opinion, it's more resistant to treatment. And then I know that I will have to use a combination treatment, as Dr. Bhavik mentioned, anti-VEGF combined with steroids, and it's more of a poor prognosis for patient, that I know that this particular patient has to be treated for many months, many years. But there is no one single biomarker which would guide me in my clinical practice for choosing specific drug. And I would like to come back to Dr. Bhavik presentation because it was very impressive, very nice presentation. I would like to point out that and ask you about poor glycemic control, because it is a significant issue in Poland, and I'm wondering how it is in your patients. And the second question is about telemedicine technology. Do you use any telemedicine technology in your clinical practice? Because we don't use in Poland, but I think that it would be very interesting, and it would simplify our diagnostic and probably treatment with this in this group of patients.
Yeah, so thank you, Dr. Anna. Just to answer Dr. Vaibhav's question first, switching over, I have seen that the IRF, the inner retinal fluid, as well as the hyperreflective foci, they reduce significantly with either an aflibercept and with the faricimab compared to the ranibizumab or even with brolucizumab. This is my personal observation, and I think there's some studies also on that. And thank you so much, Dr. Anna, for your comments. Coming to the second question, that is the telemedicine. So we do have in our organization telemedicine ongoing. However, we do not have an device which the patient can use themselves for the OCT. So as an alternative, what we do for those patients who cannot visit us, we do a home visit to them. Okay, and we have the handheld OCT device through which we can take the OCT and the fundus photograph. So patient doesn't have to visit us. The images are shared with us. We see it on the screen, and then we have a telephone conversation or video conversation with the patient. And if the patient requires injection, then patient can come directly for the injection. So I'm not sure of others in the organization or rather in the YOSI here panel who can comment on that. Second point about glycemic control, I think that's a big challenge worldwide because of the fast food is all carbohydrates. So as the food it is yummy, the sugars does not allow anyone to stop the steroids, to stop the glucose per se. But yeah, long-term measures are required. On a personal level, I do counsel the patient the first visit when I see the patient. I spent considerable amount of time explaining what is diabetes and what they need to take care of there, not just the eyes, the kidneys, the peripheral neuropathy as well. And that plays a big role, I feel, in the patient modifying his diet and his weight. So on an individual basis, it can help, but I'm not sure we should have a bigger reform where larger audience can be targeted. Thank you.
Yeah, that's true. I agree. I agree.
I think Dr. Avnish sir has a question. Sir, you can unmute yourself and please ask the panel.
Yeah, thank you, Dr. Dipanshu, and congratulations, Dr. Anna and Dr. Bhavik. Excellent presentations. I would wanted to ask and actually have a discussion further about lasers and these diabetic macular edema patients, because considering the patient load as well as the follow-ups, to actually reduce the burden of injections, the lasers do play a very significant role. So if you too can put up more light onto it, and how can you actually, if you're not doing an FFA, can you actually predict or maybe forecast, or maybe you can tell the patient that these are the OCTs possibly may requiring lasers. So if you can help us with that.
Yes, Dr.
Dr.
Anna.
Bhavik, if you can reply. Yeah.
Okay. Yeah. So, yes, laser does play a very important role. I completely agree with that. And in my treatment part as well, grid laser, modified grid laser does play an important role. And quite frequent, especially in patients for whom you have given multiple injections options, it's not resolving. So that can also buy you time to reduce the patient fatigue. You're doing the laser for the patient. The the question is very nice in terms of, because not everyone has an angiogram. Okay. So if you look at the succinate retinopathy pattern, okay, if you can zoom in the photograph or with a 90 or 78D, if you can identify the focal aneurysms, okay, which are extrafoveal, those are the ones you can target. Based on the OCT, you can have, if you have those pearl necklace sort of things, okay, signs, those are again respond very well to laser. This is the one point I can know about OCT. I can inform you about OCT. Maybe Dr. Anna, you want to add to it, or Dr. Adam or other specialists. Dr. Vaibhav, your experience on this? Maybe Dr. Vaibhav first and Dr. Adam.
Yeah, can you just repeat the question? Sorry, I was just
Yeah, the question is about use of lasers in management of persistent DME.
exactly. So I think there was a subset of patients that we used to treat, and we still treat. Maybe those focal lasers, I think I still do in my practice. Sometimes if there is a microaneurysm which has hard exudation, but it is off the fovea. It is in the macular area, but it is slightly away from the fovea. So that will at least help in long-term regression. If I'm after an angiography, if I make sure that that is the culprit for the edema, then a parafoveal macular edema, maybe even a pre-operative pre-cataract surgery, parafoveal edema, I would sometimes very rarely treat with a focal laser. But grid laser, and I don't have the availability of the other sub-threshold lasers with me, but if somebody has, they would be happy to know their opinion about sub-threshold laser as well. Dr. Adam, Dr. Anna, your opinion on the lasers and DME? Do you use it in your practice?
Yes, I use laser in my practice. I always try not to forget about laser treatment. I use laser in extrafoveal edema. I also use micropulse laser, but it's effective if the central foveal thickness is less than 400 microns. But you can always combine micropulse laser with anti-VEGF injections. And of course, I use laser in proliferative retinopathy. Then I laser the peripheral retina. And I agree with Dr. Bhavik, and I agree with you about the importance of underlying the role of laser in diabetic retinopathy.
Thank you. And has the ultra wide field imaging changed your practice somewhat? Do you think that persistent refractory DME with a lot of CNP areas, especially peripheral CNP areas, which are missed out during your evaluation, or if you see that's there, does that reduce the VEGF load by doing a laser, just a targeted laser in the CNP areas? Does that have an effect on the DME as well? So in a PDR patient that has persistent DME, you've been treating with anti-VEGF, does not improve beyond a certain extent, but you go ahead, do a ultra-wide field imaging, you see there are certain areas that are still left very peripheral near the aura. What to do this? I mean, do you laser that area and do you find that there's a change in DME?
Yes, of course. I think that the combining the combined therapy is the solution in DME patients. Yes, yes, I agree.
I will talk about the ultra-wide field imaging in a moment.
All right, sir. Shall we move to the next talk? If
Yes,
there are no
please.
more questions. All right. So now I would like to introduce the Professor Dr. Adam. His talk will be on multimodal retinal imaging insights from Poland. Over to you, sir. So you're muted. So can you unmute yourself?
Okay, sorry, I have too many screens open.
Yeah, we can hear you. Your slides are
Okay,
visible.
very so. Thank you very much for invitation. I hope you will enjoy my talk. It's going to be about the ophthalmic model, multimodal imaging in diabetic retinopathy, because this topic is about diabetic retinopathy. So we are in Katowice. We both work with Professor Nowinska in Katowice. So this is where it is. It's South Poland, Central Europe. Katowice and Silesia is very known for, it's one of the industries, region, most industrialized region in Europe, especially because of the coal mine that's deposited underneath, and also steelwork. So at the beginning it was very dirty. Right now it's changing. Obviously, everybody's switching from coal mines to other things. But we are going to talk about the diabetic retinopathy and how to diagnose it and then monitor the patient. So this is basically the pathophysiology of diabetic retinopathy. We've already talked about this, so I'm not going to read well on that. Ophthalmic imaging. So what do we have? We have the fundus photography. We have also autofluorescence, something that's not often used, unfortunately, not as often as it should be. It's especially useful in nevi. But if you have a patient who has undergone, let's say, yellow laser peripheral laser therapy, autofluorescence is also very helpful because it can show you clearly where the spots are, contrary to fundus photo, that's sometimes not as clear. Angiography, naturally, something that we still use and still we are going to use in a couple of decades, probably. Then we have retroillumination, that's something new, that's the invention of NIDEC. Whether it's so useful in cases of diabetic retinopathy, I don't know. It's mostly used in cases of drusen. Then we have one and only OCT. So yes, we use this especially, and OCT is getting traction because we are getting into far periphery also with the addition to OCT, which is the angiography without contrast, so the angio-OCT. We have ultrasound that's still being used in ophthalmic imaging. And then we have something that's microperimetry. Is it useful? It's mostly useful for some studies, clinical trials, whether it's useful in clinic, not so much probably. And then oximetry, it's another new addition, the ability to see the perfusion and the oxygenation of the blood vessels. It's also time will tell if it's really necessary to use this and whether it's useful in diabetic retinopathy. Okay, sorry. I need to switch this laser. Okay, so this is the smallest Polish coin. I'm not sure how large is the rupiah, but this is the challenge that we have in ophthalmology, right? That after all, the retina is just tiny, right? It's tiny compared to, let's say, heart. And imaging is going to be always a challenge. This is a mosaic, by the way, composed of 6 different 6 different images made on ADON. So this is like this middle field fundus camera, and this is probably the furthest you can go right now because it's 6 images composed of 100 degrees images. So that's the furthest you can get. We still are, let's say, 70%. We are 30% short of all the retina. So before we start, we need to understand a few things. The first thing is the confocal system versus the non-confocal system. So a non-confocal system, every fundus camera or every OCT works the same. So you have a light source, you have a mirror, then you have some sort of lenses, then it goes to the eye, the light is being reflected, it goes through this mirror that's usually just one side mirror, and then hits the sensor. The problem is you see everything, right? In that kind of optical system. So you'll see eyelashes, you will see floaters. If there is a cataract, you will see also cataract. If there is anything within the lens to the retina, it's going to have an impact on the image. So then, because of that, a man called Goldman, the same guy who invented Goldman tonometry, had an idea to put something like this. So to put an aperture between the lens. Between the sensor. This principle is used in a slit lamp. So because Goldman also had innovated, not invented, but innovated the slit lamp, he put the aperture, and all the slit lamps are more or less a type of confocal system. This allows you to clearly see only things coming from, let's say, retina, right? So this is how clear those images from confocal systems are. Confocality has naturally drawbacks as well. So firstly, you cannot, if the confocal plane is very thin, you are not going to see nevi, right? So that's the first problem, right? Because if it's only for the retina that you want to see, you won't see anything that's behind. Another problem is sometimes you want to see floaters in cases of uveitis, right? In that case, you shouldn't use confocal system because you won't see a progression, right? If you want to, just check the progression of the uveitis, then using confocal system doesn't make any sense. And another problem is that if you look at the equation of the resolution in confocal system, you will see that the resolution is inversely correlated with the field of view. So in confocal system, you can have very high resolution at the expense of the field of view. So that's the problem, right? You have very clear images, very high resolution, but not such a huge field of view as with non-confocal system. Okay, so that's the idea. The light that's, let's say, between the lens and the retina the scattered light is not being transformed to the sensor, right? That's the confocal system. Okay, let me just move to another one. Okay, so that's basically the comparison of confocal system and traditional fundus camera. In traditional fundus camera, you are going to see Benson disease. In cases of confocal system, this Benson disease is blocked, yet you see some sort of shadowing on this, but it clearly shows you the difference. And then we are going to talk about sorry. That's another clinical case. The same patient, image with a pretty old fundus camera and also the confocal system. So just to make sure that this is the same image, right? You see that this is here, this is here, right? I need to get this. This pigment is here. So yes, this is the same patient, image on the same day with 2 different systems. And you see that confocal is much better. Naturally, we also have other things. We have infrared, autofluorescence. Infrared and autofluorescence are very nice to see choroid. Infrared is very useful to see choroid, as you can see choroidal vessels. So in cases of a patient who is, let's say, having laser therapy and you want to see where the laser spots are clearly, infrared is going to be nice. Autofluorescence, it's not so useful in cases of diabetic retinopathy as much as like here in cases of AMD and, let's say, pigmented deposits diseases. So we need to understand that what the companies are trying to sell us, it's not really what it is. It's called marketing. So when it comes to nomenclature, basically 50 degrees of field of view is equal to 12 by 12 millimeters. So if you have an OCT and the people who sell the OCT tell you, well, it's, you know, wide field because you can get 12 by 12 millimeters. Well, it's actually not. 12 by 12 is just a standard fundus camera. Wide angle system are more or less 60 to 100 degrees, right? This is what we call. And then we have ultra wide field system, which are more or less more than 110 degrees. So this is basically a nomenclature proposed in one paper on ultra-wide field imaging, and this is what we use. So this is basically an ultra-wide field imaging called OPTOS. As I mentioned, as you can imagine, this is the furthest reaching fundus camera that's right now. As I talked about confocal microscopy, this is definitely a not confocal system. You can see eyelashes, you can see also some floaters, but on the other side, the good thing is it's one image and you can capture something like 200 degrees. Newer optoses, they also allow you to create mosaics, so then you can have up to 240 degrees. Another examples. This is the confocal. These are two confocal systems. You can compare it to what you can see with OPTOS. The good thing about the scanning fundus cameras is basically that you can do non-mydriatic. So this patient doesn't have mydriasis. He has a 1.9 millimeter pupil. He has actually a severe kidney injury, and because of that, we actually atropine didn't work on him, and any other tropicamide didn't work. So that's basically what you can get still without mydriasis with a very, very narrow pupil. And this is the comparison. So naturally, you can get the mosaics. Mosaics are nice if the patient is cooperative, right? So that's the thing. You can use mosaics if you have patient who really follows your guidelines. And another thing, it's time consuming, because in order to get this, you need to have 6 images and versus 1 image of that, right? So that's the problem. However, you can see here that this image is less sharp. You see some floaters. You can see shadowing from the floater. And also you see eyelashes. And also resolution of this image is much lower when it comes to like a very important region of macula or the optic nerve. You can see here this. Plus, when it comes to OPTOS, the older OPTOSes were composed of 2 lasers. So you had the red-green laser, and you can see that this image is basically a false color. It's composed of red, as you can see, and then you can see green. So that's why it's not really clear. It's not really like you see in the fundoscopy. This is another system. This is the system from Zeiss. It's called Zeiss Clarus. It also allows you to get wide field imaging, and this is fluorescein angiography in patient who has, as you can see here, a severe case of proliferative retinopathy. And that's stretching from the optic nerve up to along the upper arcade, and then that's how it looks in the Clarus. Clarus is an interesting system because it's a partially confocal system. So it's confocal from the cornea to the retina. So you don't see eyelashes, you don't see dirt on the lens, but you can see things like this, because with add-on, that's the problem, that you cannot really extend, if you have some extension, if you have proliferation like here, you cannot really see them because it's going to be cut. With Optos, you can clearly see this. It's also very clear. You can clearly see and depict the lesions. This is compared to the laser that's in Optos. Optos, on the other side, when it comes to fluorescein angiography, beats every other system because it has monochromatic laser. So Optos is basically an SLO-based system. Because of that, you have a very narrow bandwidth that's just exciting the fluorescein dye. And then you don't have any other dyes that are in the retina that are being excited by other wavelengths, like you see here, right? You see here that it's not just the fluorescein that's excited, but also probably lipofuscin, maybe other dyes, maybe xanthophyll. It's also creating some fluorescence. With laser system, there is only dye that's being excited. So this is why you have such a high contrast between non-perfusion and let's say perfusion and PDRs. So by the way, this patient, look at the fundus. This fundus doesn't really look that bad, right? If you just do fundoscopy, you can say, oh yeah, sure, there are some hard exudates, there are some sort of hemorrhages. It doesn't look really proliferative. And when you do the ultra-wide field fluorescein angiography, you can clearly see there are two spots on which are showing you the proliferation, neovascularization. So you have neovascularization here, plus everything here is non-perfused. Everything to the nasal side, non-perfusion, far periphery, non-perfused, compared to, okay, you can be tempted to call this mild, or I'm sorry, not mild, but moderate NPDR. So this is basically why you should always do, in cases of diabetic retinopathy, if you can, if you have access, you should always do fluorescein angiography if you have access to ultrawide field, and you see any changes that are extending from mild, more than mild. We usually use the Optos to image because sometimes you have cases like this, right? And that's another case which shows you how important is imaging the periphery, because you can then see lack of perfusion, and as we know, diabetic retinopathy starts actually in periphery, right? Another thing is that after you did the laser, also doing fluorescein angiography helps you to determine spots which were spared by the laser therapy and can correct this, and you can clearly see that there is some more laser to be done in that patient. Yes, another thing, again, a patient that doesn't have such an extensive retinopathy here. However, in the periphery, lack of perfusion, leaking vessels, again, this shows you the why you should do it. NGO-CT. NGO-CT, that was introduced 2014 to 2015 commercially. Something that was really hoped that it will replace fluorescein angiography. Now we see it's useful in CSR, it's useful in AMD, however, not so much in diabetic retinopathy yet, because also we have ultra-wide field systems that allow us to go into far periphery. So this is a patient who has a proliferative version of diabetic retinopathy, and you can see here everything. The patient has everything that you can have in diabetic retinopathy. So microaneurysms, vessel loops, non-perfusion, neovascularization, beading, what else? Non-perfusion again. Here maybe some IRMA. So that's the beauty of the OCT angiography, that it's extremely high resolution, right? That's the resolution of the OCT compared to resolution of the fundus camera. So you can clearly see small, tiny little changes. Is it clinically relevant? Not so much, to be honest. Unfortunately, we still would treat this patient the very same way as we would treat the patient who had fluorescein angiography and had the same thing. Something that's newer is the ultra-wide field angio-OCT. So there are two systems, there are several systems already. So you have the Canon, you have the Zeiss Plex Elite, and then you have the towards SPY and the Belkin, no, not Belkin, Intelligent OCT something, Intelli, it's called. So there are several swept source system. They have to be swept source because it's much faster, and this is more or less 22 millimeters, 22 times 22 millimeters. In that case, you can clearly see severe diabetic proliferations extending from the optic nerve head, plus in the periphery, see the lack of perfusion. This is something that you can use because naturally it's quite difficult to have fluorescein angiography on every follow-up. So here, when you have the laser treatment, you can basically superimpose on the SLO system, and then you can see where these spots from the laser are. There is also a 3D mode for, let me show this. There is also a 3D mode available for OCT angiography. So you can see what's the depth of the incursion of the CNV, of the MNV, sorry, on the NVD in cases like this. And then it might be useful for the vitreoretinal surgeon. Okay, we've already seen that, so that. Yes, this is what I told you. SLO is great for showing you this laser spots. So maybe that's also something, an alternative to fluorescein angiography. Yes, another case that shows you that you can more or less right now get into mid-periphery with OCT angiography. Naturally, you don't see leakage. You can expect leakage here, but everything that's seen here. So more or less, this technology, if it reaches far periphery, will be able to quite compete with fluorescein angiography. Compete, maybe not so much replace, but compete. Another great feature is that this technology, swept source, is very permeable by the lens. If you have a traditional fundus camera, cataract will hinder your efforts to get nice and clear images. With swept source, it's much easier. So this was a patient that we couldn't do laser, we couldn't do fluorescein angiography, yet I was able to get a very clear images of the proliferations within the NVE. So we knew before the cataract that the patient needs to be, the cataract has to be done very quickly, promptly, and then laser treatment followed soon. That's the wide field scan of the macula. You can also see, of the same patient, you can also see here the macular edema. Right. Another great feature is the en-face. En-face allows you to differentiate when you do the fluorescein angiography, differentiate between the, let's say, drusen, deposit, hard exudates versus the microaneurysms. Because unfortunately, microaneurysms and hard exudates will look quite similar, especially on this spectral domain systems. So always compare the en-face to the fluorescein to the OCT angiography, like here, right? You can see that these are what's hyperreflective here. It's going to be drusen, our hard exudates. So you see that not everything that's basically like this tiny little bright spots are nothing more than the microaneurysms. Sometimes it's just the heart exostates. So what are we looking for? We can see no flow, neovascularization, microvascular change, and the laser impacts. That's another thing, macular edema and heart exostates. This is what I told you. Heart exostates are going to be quite hyperreflective. So use on-face OCT, it's very useful. Last but not least, we have the ultrasound. Ultrasound is still necessary in cases of vitreous hemorrhage or in cases of very dense cataracts when you cannot see anything. So yes, we are going to use ultrasounds in future because the light is not as permeable as the sound. What are we looking for? Detachment, we can see naturally proliferations and other structures like the very dense proliferations, and neovascularization can also be seen. So last but, so we are arriving at my topic, which is the multimodal imaging. Naturally, the best thing is to have an all-in-one system. So an OCT combined with fluorescein angiography, combined with autofluorescence, combined with fluorescein angiography, combined with fundus photo. Yet these systems are very expensive and not available. So there is a way to combine them. There are also other programs that can link OCTs to OCT angiography, to fluorescein angiography, and the fundus photo, and then provide you one of the systems. This is the ZEISS Forum, but there are others like Optos viewer, like Symphony from Topcon, and also cheaper versions available that can combine you. And this allows you really to treat your patient, monitor them, and combine with the view of the macular thickness, this can allow you. Another thing is the artificial intelligence. This system is owned by ADON. This is an automatic system that allows you to monitor and to diagnose and to classify the diabetic retinopathy. It's in Polish, but it can be in any other language. This is the patient who has been diagnosed by the system with diabetic retinopathy. The system classifies this based on the standard ETDRS classification. So in that patient, this is the moderate, and then here it's severe diabetic retinopathy. So the left eye, severe, right eye, mild, and we can see why the system created this based on the classification. So the system will show you where the lesions are that the system classified, why it was classified, and then it will also give you confidence interval for that. So thank you very much for your attention. I'm on YouTube, Ocular Imaging Aficionado, where I review medical devices. So if you would like to see my reviews, please enjoy. Thank you very much. And I'm open to any questions.
Thank you, Professor Dr. Anam. That was an extensive talk. I think you have very well covered right from the basics, and especially with the introduction of these ocular imaging, especially with the wide field imagings. The game has changed. I think the practice scenarios have changed drastically. So I have a question for you. Like, what is your how does the practice work back in Poland? Like, how does it work? Do you guys image every patient that comes to OPD, or only when it is required?
We have so every patient who is diagnosed with type 2 diabetes should have eye screening within 5 years from the diagnosis, unless the diabetic retinopathy is totally uncontrolled. If the patient has high albuminuria, then the patient should be referred immediately to the eye doctor. In that cases, we usually do the photography on Optos or on ADON. If this shows signs of moderate diabetic retinopathy and the patient doesn't have contraindication, we would perform fluorescein angiography. Can you hear me?
Yes, we can hear you very well.
Okay.
Yeah,
Okay.
we
So
can hear
that's
you.
that.
Please go ahead.
Okay. So that's did you
Doctor,
hear my answer? So the answer was basically everybody gets photos. People who have moderate and above will get the fluorescein angiography.
right. Dr. Vaibhav, Dr. Bhavik, any questions for me?
So if you set up a practice now, Dr. Adam, and so if you want to, which machines do you think, in your experience, are critical for a retina surgeon to have at this point of time, which is going to be dictating the, the treatment after all. So what do you recommend?
Well, I mean, it all depends on the budget, right? Because I would just, the short answer is Optos Silverstone, because you have far periphery, OCT, plus you have fluorescein angiography and you have the photo. But I think it costs like $400,000. So it's going to be very limited for a couple of times. It really depends on the budget, because I would say for the VR surgeon, the most important thing is still periphery, and also I would rather suggest getting the laser-based systems. And traditional fundus cameras will not work in cases of hemorrhages, in cases of cataracts. So anything that has some sort of scanning capability, it's much more. It's going to be more useful in that cases. I mean, ADON is a nice system. I didn't. ADON is a nice system because it has. It's still much cheaper than Clarus. It's cheaper than Optos. Yet you can do mosaics and it works, right? So if you have time and you don't have so much money, you can use this. I know there is also MicroClear from Apollo system. It's also more. It's cheaper. I haven't got the experience with this, so I cannot really talk about this. It's an SLO-based system, so it's also confocal. So some boxes are ticked. That would be my take. But Optos is still the king of retinal imaging when it comes to periphery. If you are medical retina and you're more into macula, Optos is not so great because the resolution in macula, it's not nice. Plus, fluorescein angiography doesn't allow you to switch eyes very fast. And you also don't have a movie. And movie is the option to have a movie for the macula. It's useful, especially for a CSR, especially for early AMD. So if you're medical, I would look for something else than Optos. If you're VR, Optos.
Right. If any other questions? If there are no more questions, I think we can move on to the last talk of the session. We have a very young and dynamic Dr. Vaibhav Sethi, a prolific VR surgeon from New Delhi, India. He will be speaking on bleeders and breaks, crucial lessons from diabetic vitrectomy. Over to you, Dr. Vaibhav.
Thank you. Is the screen visible, and can you see the?
Yes, so you're visible and audible as well.
Yes.
Thank you.
Great. So taking you away from macular edema, I'll be going towards bleeders and breaks, something which is a little interesting for us to learn. So I'll be taking it to as a perspective of the crucial lessons that we all learn when we handle diabetic vitrectomy, because we know diabetic vitrectomies is something very different from the normal vitrectomy that we do. So lesson number one, it's not always a great idea to peel over a fibrovascular proliferation over the optic nerve head. And I'll give you an example of this patient of mine. This was a young diabetic having vitreous hemorrhage, not treated previously, uncontrolled diabetic. After clearing the hemorrhage, this is the situation I was in. There was a kind of a flat fibrovascular proliferation over the optic nerve head. So I thought maybe it's a good idea, as usual, just slowly take your time and remove the extension and the traction over the optic nerve head. you can see a minor ooze happening over the nerve, but I was not very worried about it. I increased the IOP at this point. But gradually, my attention veered off towards the membrane dissection and the clearing of the membrane around that area. So I continued my surgery, and I realized that the ooze had increased significantly during this period. So I tried to just clear off and went back to that area, mechanically compressing it, increasing the IOP. But I was aware, being a diabetic, you can't increase it too much. So I thought I'll tackle it later. And that is what I realized, that it's not good to tackle such a hemorrhage later on, because what happens is it makes a mess out of the whole situation. So you can see what happens. You create another membrane, a clot membrane, which gradually oozes over the macula, the posterior pole, making your life even tougher. So previously I was just taking care of fibrovascular proliferation, but now I'm taking care of a large clot over the macula and the optic nerve head, and also it impairs your view. You don't know which plane you're dissecting, and you can very critical. If you make a break here, then your case becomes very tricky. So what I did was I went. A lot of maneuvers did not work, so I finally went under air and aspirated the blood clot and left a small clump over the optic nerve head. Fortunately, over a period of 4 weeks, the patient did pretty well, but this was a learning curve towards me. It's not always a good idea to peel off this fibrovascular stalk. The second lesson, less is more, which I've realized, and we all do realize in our practice when we increase in our experience, that it's important to deal with only the thing that is actually causing the problem. And you can leave what you can leave safely. So this is a patient, again a diabetic, not lasered. So there was a nasal fibrovascular proliferation after clearing the organized hemorrhage. I realized that the main issue was nasal to the optic nerve head. And so the main focus right now was to remove this proliferation and clear the organized hemorrhage. There was also a subretinal hemorrhage here, which was extending beyond the fibrovascular proliferation and the focus. So the focus should be kept minimal. The important thing here is to get the overall visual improvement. It's important for us to find a second membrane, find the membrane dissection properly, try to delaminate it with the help of your cutter or whatever you are comfortable with, so that you create a plane. After you create a plane, you can see that there was a fibrovascular tissue over the organized subretinal hemorrhage. So the yellowish color itself indicates it's a long-standing hemorrhage that happened subretinally. So you don't have to worry about the subretinal hemorrhage right now. What you need to do is just clear off the vitreous hemorrhage, clear off the traction as much as possible. The best way of clearing of traction is to segment it. Just these are bleed happening, you just do a fine cautery, clear off you can see the macula is fine except for a few island striations, which I did not feel the need of doing island peeling. And the important part is do a thorough laser. Examine the periphery, clear the hemorrhage, whichever you can, having a balance, and clear the hemorrhage, organized hemorrhage around the aura area all across. And finally, what I did was I left that subretinal hemorrhage right there, and I finally injected anti-VEGF as well as under air, and finally injected gas and left this patient under gas with positioning. So this patient actually did pretty well, because I did not chase after something which I saw later on, but my plan was very clear. Lesson number 3. What looks easy is not always easy, especially in diabetic vitrectomies. Tackle flat NVEs with caution. This is something which we see. So this was a patient, again, the surgery took some time. Patient had developed some amount of corneal haze, corneal edema. You can see that was disturbing my vision. And this was a flat NVE that was there. I was going from an inside out approach. I was able to clear the fibrovascular stalk near the arcade, but beyond that, I had some issues. So instead of going and following the key maneuvers of actually going outside in as well, removing the vitreous all around, I thought I would be able to get away by just clearing off this tissue, but I was wrong. So the reason was, what happens is, here you can see I created an hydrogen break just with my cannula, my suction cannula, because retina here in such cases is very thin, and with a hemorrhage and a flat membrane, it becomes very tricky. So now the problem starts is, there's a thin retina there. There's still a residual large flat membrane that is causing an issue. And along with that, my view is getting a little bad and I'm creating breaks. So this is what needs to be avoided, and then what happened when you're starting up, or when you do things with overconfidence, you do not follow your principles properly. So you can have. So what happens is, along with one break, I thought I'll still continue manually. This was the time I should have switched to a bimanual dissection. The view was not very good. It was more of a clearing the hemorrhage. So finally, when I thought I'll just peel it off, but you see the by peeling it off, it'll never come off. This kind of flat membrane never comes off with just an island peel because there's no counter traction. And what I'm just doing is enlarging the break that is there. I again go back to clear the hemorrhage. So this is a vicious cycle. So instead of having no breaks there, I've already created 3 tiny breaks. Now this flat, though the membrane is becoming smaller, my breaks are becoming bigger. So by doing a cautery, which was I think a little more destructive, I created a third break. And finally, I thought I'll just go ahead and do a bimanual dissection, which was too late to be done. So the other thing is that when you have a break around the traction and this traction, you have to remove all the traction around the break. So what I did was finally, though it was little, I was lucky it was off the arcade. So I had to do one small kind of a small retinectomy or retinotomy to clear the membrane around that area. Otherwise, if I left membrane along with the break, then this patient would not have been benefited. Actually, there would have been issue. And so I went ahead under air, flattened the retina, made sure I did a good laser, removed all the membrane around the breaks, making sure I was secure and comfortable. And then finally, leaving the patient. And this patient, I thought it was better leaving under the oil. You can see the state of the cornea is not very healthy. There were DM folds and scraped off. So in conclusion, what I like to say is every case poses a new challenge, especially in diabetic vitrectomies. We learn from every case. There's still the cases we still learn from. No case is easy. You can never say that this case is going to be easier than the other case because they actually turn out to be tougher. Preoperative assessment is very important. Proper planning and counseling is essential. Prior anti-VEGF injection plays an important role when you can see the fibrovascular stalk and if it's very vascular. Breaks during dissection warrant complete removal of the membrane and traction around them. That's very, very important. And visualizing and removing the second membrane is very, very important to have a very good dissection and to create minimal iatrogenic breaks. So less is more in VR surgery, especially diabetic vitrectomies. When you think it will be an easy case, it won't be. You don't have to remove all membranes, just the important ones causing the traction, because you need to be taking care of, after all, the macula, the posterior pole should be without traction, and other membranes can be trimmed off accordingly. Once a break has happened, you'll have to go full ahead and you'll have to remove all the membranes that time, or especially around the breaks, because otherwise the case will never be complete. Thank you very much.
Thank you. Thank you, Dr. Vaibhav. Those videos were very insightful and I myself learned a lot. And also one crucial point is less is more. Very well highlighted point. Now I would like to open the discussion to Dr. Bhavik, Professor Anam and Dr. Anna, if they would like to comment.
Yeah, one question from Dr. Karthikeya Singh to everyone. So when do you plan to give anti-VEGF before closing a case of proliferative diabetic retinopathy? Yeah, I think with that we can start the panel discussion.
Is the patient lasered or not?
Maybe with or without, what would be your algorithm? It's an open question. The laser point of view is not mentioned in the question. Karthik, you are there. You can add on to that.
Yeah.
Yeah.
Am I audible?
Yes, Dr. Karthikeya, you're audible.
Yeah. So while doing a case of PDR, like there are few cases where you see a lot of proliferation, lot of flat NVs which you have lasered well. But do you like to add anti-VEGF before closing a case? Let it be a gas or oil closer. So what is your take on that, Dr. Vaibhav, Dr. Anna, and to everyone else, to Dr. Adam?
Yes, actually, you're right. So in certain cases, you realize that there's a DME as well, sometimes after the vitreous hemorrhage.
Right.
And sometimes you feel that, anti-VEGF may help in certain, there could be some residual thin vitreous hemorrhage which you're not able to get during the surgery as well, because there's a phakic patient, there's a clear lens, you don't want to sacrifice the lens. So in certain cases, when you think that you've not done enough laser, you want some time that you can do a post-operative laser as well. Ideally, the best way is to do laser and close the case, complete laser. But if you're not able to get for it, then in those cases, I feel I do an anti-VEGF injection post the surgery.
Yeah. So I, like as you rightly said, I prefer to give it when there is a significant macular edema, which I see after clearing the vitreous hemorrhage. And then in some cases where we see a lot of NVs, florid NVs, though those have not made a proliferative stage, but they are still there. So in those cases, I like to add sometime. And in few cases where there was traction, which can actually lead to Cron's syndrome, we avoid giving anti-VEGF in pre-op. So in those cases also, if there was a big FVP, then I would add. These are my points. Just like, I think it's almost the same for all of us.
Dr. Anna and Adam. Yes,
Dr. Adam.
Yes, I would say it all depends on the how well on several things. Firstly, if you have tractions, if the let's say you have those growing type of neovascularization, in that case, if you do the anti-VEGF, the patient is not lasered, you'll get the RD, right? That's very soon. Another problem is if you do the anti-VEGF and the patient is not lasered, you can actually very nicely control the patient. But if the patient is lost to follow up and doesn't come for, let's say, next injection, and for several months, then he will get RD, he will get proliferations, it will all be done. So you need, I mean, actually we published 2 papers on getting the diabetic retinopathy under controlled with bevacizumab. Just the diabetic retinopathy, not the DME. And it works very well. It actually works much nicer than laser because you don't have any problems with that comes with laser. The patient sees better. The patient has much milder form of diabetic retinopathy. And we all see this with the DME when we get the patient. However, you need to remember there will be a rebound, like, no other rebound after you cease the treatment. So you need to be very, very careful, assess the follow-upness, the compliance of the patient, and also the type of proliferations and also the state of the laser.
Right.
Professor Anna?
Well, preparing myself for proliferative retinopathy vitrectomy, I usually think about the lens status. I try to do the phaco first to have a pseudophakic patient. And at the end of the surgery, I quite often use triamcinolone and anti-VEGF, but at the end of the surgery, I inject it to the air and then do the air-gas exchange.
Dr. Karthikeya, did we have the second question also answered? One by Dr. Bhavik.
Do you give anti-VEGFs prior to all diabetic vitrectomies? Apollo. Yeah, that's what we were discussing on the same.
Okay.
Dr. Adam, I think he has answered. He has discussed the point.
I don't do vitrectomy, so I cannot speak for that.
Okay. Devakant sir, any comments from you before we? Yeah.
Yeah. Hi, Prasanna. You want comments on the question or otherwise?
Yes, sir. We can take it forward from scientific to the MoU as well. Yeah. If we are done with the.
Right. So again, as Dr. Bhavik has asked about, no, I do not inject in all our cases. So number one, when I see, large neovascularization areas which I know will bleed when I do vitrectomy, then I go ahead and inject. Otherwise, in simple diabetic vitrectomies or when I don't have a very good view, then I do not inject. So we also have to be very selective while injecting in these cases, right? Dr. Vaibhav, your input? Do you inject always?
No, I think same thought process. as you say, that injection, as it also adds on to the cost of the patient surgery. We take it in those indicated cases, especially when you have a very vascular proliferation, and you think that it's going to bleed on table, then in those cases, definitely I'll be giving 3 to 5 days prior. And in certain cases where it's already a fibrosed proliferation, as you mentioned, those cases, I think I manage it without the anti-VEGF injection.
Right. I think, yeah, that's the usual protocol. So again, great presentations by all the speakers. It was a very insightful session, and we learned a lot. And it was very insightful from Dr. Anna's presentation about how they go about doing injections in their country, and likewise in Dr. Adams' presentation about the visualization part of it. So now we would want to talk more about how both our societies, both our countries can get together and work towards, of course, the clinical part of things, how to exchange ideas, and also how to interact more on a regular basis. Our society, Young Ophthalmologist Society, is focused a lot on people who have just finished residency, part of their residency, doing fellowships, or early into practice, less than 40 years of age. So we would want to know from both of you, or if others are there, how we can interact more, collaborate, and what things do you think that we can work together on in the Dr. Adam, your points first.
So we are also very happy. Our society is, we are actually a society that's meant for the education of doctors, of ophthalmologists, and of the residents. This is why we are Academy, the Polish Academy of Ophthalmology. We organize several congresses and also webinars. We also publish books. And so we are very much into educating, not so much into other instances of societies like like the government reforms and the policy making. This is not our goal. Our goal is basically the education for for the benefit of our patients. So that's the Polish Academy of Ophthalmology's main mission.
Amazing. And what do you suggest, Dr. Adam? Of course, we will be, getting into a memorandum of understanding. So we'll be sending
I don't.
So we'll be doing it virtually. We'll send you a. Can you hear me?
Okay.
Dr. Prasanna, am I audible? Yeah.
So you are just breaking in between, but yeah, we are able.
I'm traveling, Prasanna. Can you take over? I think there might be some technical issues. Just we can discuss about the MoU that we are talking about and YOSI. Rest of the things I'll type out, right?
Okay, sir. Yeah. So thank you, Devakant sir, and of course, Dr. Aditya for organizing this wonderful meeting. So as our president, Dr. Devakant sir was mentioning, Professor Adam and Professor Anna. So we at YOSI, so we have this MoU with the other global associative societies like, we had this with Nepal last time, and so we are trying to strengthen our collaboration and bond so that we will be able to foster collaborations and develop network where we will be able to grow together on a global platform. So that is one on the agenda why we are all here. And I think after this meeting, Devakant sir and our secretary, Dr. Nilesh, and I think Professor and Dr. Adam, along with your team, will be getting the MoU done is one that we wanted to set the ball rolling today. And the second one is the YOSICon invitation that we are very fond of is we have this annual Congress meeting of our YOSI, Young Ophthalmologist Society of India members. Last year we had, or rather this year is 2024. We are still in 2024. We had our first annual conference at New Delhi. And next year, 2025, we are going to have the second edition, which is going to be on a YOSICon International, where we are planning to have international faculty as well. And so we are planning it in September 5th, 6th, and 7th. So we are trying to send out invitations to all other global societies. And I think Poland can also help us with that, where if you guys are able to attend the meeting or your young ophthalmologists are able to be in person, we would definitely like to host you. We have finalizing on few travel grants as well with we take care of the logistics and other parts. So that is on the agenda as well. So these are two things which we wanted to discuss along with the scientific deliberations that we had. Yeah, your views, Professor Adam and Professor Anna, on the same.
Well, thank you very much, Dr. Prasanna, for your kind invitation. And well, what I can confirm from myself, we are really open for collaboration, and I think that we can learn from each other. So I'm really happy to be here.
Yeah. Thank you. Thank you for your positive response. It really matters a lot. Professor Adam, your views?
Yes, I agree. I already talked to two of our residents and early fellows that they want to come to Delhi in September. So we are happy. We would like to sign, obviously, the mode of understanding. I guess we are going to sign it now, right?
Yes.
Yes.
After the meeting is going to be concluded,
Okay.
we have to send the MoU through mail to both yourself as well as your secretariat office mail IDs, and then I think it's almost formalized. It's only that we need to get the signatures and DocuSign, which I think Dr. Devakant will be sending it to you after the meeting is
Oh,
concluded.
great.
So I
Great.
think it is as good as we are in an understanding now. It is just that the
Yes.
signatures and the formalities will be concluded after we wind up the meeting. And since Dr. Devakant, our president, is traveling, I think we'll get it done. Yeah. I think we are
Very
all.
good.
So
Hello.
yeah, I think Aditya is also joining us. Yeah, Aditya, we are just completing things. I think you can
Perfect.
give a vote of thanks and we can close the event. Yeah. Aditya, are you audible?
Yeah, I can hear you.
Yeah.
Please tell me. So well done. I think while the retina guys were doing all this, I had to do some lasers, so I just walked out and did some lasers. So apologies for my missing a part of it. And I think it was a great first innings, and all the speakers did justice. And looking forward to more such webinars, and also I'm sure we've all invited you before as well. So in September we are having a standalone Young Ophthalmology Society meeting in Delhi, and Adam has been to Delhi, so he can vouch for how good hosts we are. And of course, I would extend the invitation to everybody at PAO, and we would want to see everybody here. And it'll be absolutely our pleasure to host you guys in September. One of us will send you the details of the meeting, and please send your abstracts. And we are hoping that we can give you a whole session so that we can discuss about Poland, and we can discuss about different other things that are done differently in Poland versus here. I was hoping to get press biopia also done, because a lot of work has been done in Poland for press biopia recently as well. So hoping that we can have that in our physical meeting soon.
Okay. Okay. We are happy. We need to, because we have Christmas next week. We need to get back to I mean, I'm not cooking anything, but I need to start doing something.
I understand. No, it's very festive here as well. And you can see with Prasanna's hairstyle that we are in the Christmas mood. And we are all ready with our Christmas celebrations and going for our holidays here as well.
Yeah. I think with that, we can conclude, Aditya.
Yes, of course. And next time when you come, you have to go to Varanasi, where Karthikeya is sitting right now. Is from Varanasi. It's the oldest city in the world.
Yeah. So with that, thank you, dear all, for this wonderful MoU webinar. To all the 4 speakers, Professor Anna, Dr. Bhavik, Professor Adam, Dr. Vaibhav, taking your time on a Saturday morning or a evening for whatever time zones we all are in. So again, kudos to Aditya for getting us all together today. And without holding much time, I think we'll bring this meeting to a close. And we would also like to thank Numerotech for also giving us the logistics of the Zoom and YouTube for this link. And
Prasanna, you took a photo?
yeah, we'll take a quick photo.
Yeah,
So
we'll take a photo.
yeah. Thank you, dear all. We'll close up with the mandatory yo photo. So we have this mandatory yo photo, and thank you again, everybody, Deepanshu and Avanish, whoever was able to join us, along with our friends from Poland. Request all to Avanish sir, Dr. Dominica, if you can on your picture.
Divakant will also come.
Yeah.
He'll be before.
Yeah, 3, 2, 1. One more. Yeah. 3, 2, 1. Done. Yeah. Thank you.
See you. Thank you.
See you. Thank you very
Thank
much.
you.
Bye.
Merry Christmas.
Bye.
Thank you.
Merry
Have a nice
Christmas.
Saturday.
Thank you.
Manjula ma'am, we can go offline.
Merry Christmas.
Yeah. Happy Christmas.
Thank you. Merry Christmas. Thank you.
Vaibhav sir, Happy Christmas. Karthikeya, Happy Christmas.
Happy Christmas.
Bye.
Bye.